Assalamu alaikum. Good afternoon, everyone. First, I would like to thank MESTRO for giving me the opportunity to present to you today. And special thanks to you, Dr. Isa, for arranging and organizing such an important course that will help our region definitely. My name is Mohammed Aldehaim. I'm a radiation oncologist in Riyadh. And inshallah, in the next 30 minutes, I'll speak to you about locally advanced laryngeal cancer. Here is the outline of my presentation. I would like to review the literature that discuss the rule of upfront surgery and the larynx preservation approach. So we'll have some time reviewing the VA larynx trial, and then we'll move on to discuss the sequence of different regimen of the larynx preservation with chemo and radiotherapy, with the R2G9111, then Gortic 2000-2001, and then TAX 324. And then with the remaining time, we'll have some to discuss about the functional outcome after the organ preservation. I'll try to discuss quickly about the management of acute and late toxicity. And because of the time limitation, probably I'll focus mostly on the dysphagia. The larynx cancer accounted for a third of all head and neck malignancies in the United States. There is 13,000 patients diagnosed annually, and two-thirds of those are having a true vocal cord disease involvement. The good things is that more than 90% of these glottic cancer are detected in early stages in situ T1 or T2, and the most common histology is the squamous cell carcinoma, accounting for 95% of all cases. And we can see the incidence difference based on race in the United States. The most common is the black male, followed by the white male, and then the female, either white or black. So when we talk about locally advanced laryngeal cancer, we are talking about stage 3 as well as stage 4A disease. And also we include the T3 and 0 and anything T2 and above with positive lymph nodes. And I agree with Dr. Wissam that total laryngectomy is the standard of care for well-selected patients who had locally advanced larynx cancer. However, total laryngectomy is not an easy procedure. There is a consequence happen to the patients that might affect their life. They will have some natural voice issues. They have some issue with taste and smell of food. The good thing that the oral feeding will be maintained in most of cases. And because of these side effects, their quality of life had impact in case of depression, anxiety, that will lead to social isolations. So that's why there's potential for hoping for a larynx preservations by using non-surgical treatment with chemotherapy or radiotherapy in different sequence to treat larynx cancer without compromising the overall survival. However, this is need to be in appropriate patient selections that depend on a variety of factors, some of which related to the patient, some of which related to the tumor, and we really need to evaluate these patients carefully to assess their baseline functions of their larynx. Some factor to consider for laryngeal preservation is we need to make sure that they are having freedom from aspirations. We need to evaluate these patients along with our colleague in ENT for the needs of the tracheostomy or not. Then with the help also with our colleague in speech language pathology, we need to assess their swallowing function and to assess the need whether the G-tube is needed or not. Also to evaluate their voice, and of course, we need to have a patient's preference. So these things that really need to be discussed in a true multidisciplinary setting. The first trial we'll discuss is the VA larynx trial, published long time ago in the New England Journal of Medicine back in 1991. And at that time, The standard of care was surgery followed by adjuvant radiotherapy if needed. And this was the first trial, is tried to compare the rule of induction chemo followed by radiations and compare it to the standard arm, as it's shown here in the study schema. So they randomized 332 patients to the standard arm, again, which is the laryngectomy, followed by adjuvant post-op radiotherapy with different doses of radiation based on the risk, as explained clearly in the trial. The tested arm is the using of the induction chemo. So they use initially 2 cycles of cisplatin and 5-FU every 3 weeks, and then they evaluate the response after 2 cycles. In case of there is no response, then these patients will be automatically shifted to the laryngectomy arm. And if there is good partial or complete response, these patients will having additional cycles of 5-FU and cisplatin, and then they will end up receiving definitive radiotherapy with those that is slightly more to the primary site compared to the lymph nodes. In this trial, they exclude the metastatic patients, they exclude the unresectable patients, they exclude patients who had a prior head and neck radiotherapy or prior cancer treatment. So bottom line, there is no difference in overall survival or disease-free survival comparing both arms with not statistical significance p-value. There are so important lessons coming out from the VA larynx, and they analyze the pattern of failure with the induction chemo followed by the radiations. And what they notice is that there is tendency and there is a decrease in the distant metastatic arm favoring the induction chemo with 11% compared to 17% with significant p-value, but also they notice high local failure with 12% versus 2% with significant p-value. The good thing is that they were able to preserve the larynx at 64% of these patients at 2 years. And then who's the one needed the laryngectomy, and when they need the laryngectomy is that they found that 18% laryngectomy happened after induction chemo alone for persistent tumor, and then 11% happened after the induction followed by the radiations, and then 7% happened recurrence later on. The T4 patients, they've noticed that they required salvage laryngectomy more than half of these patients, around 56%. So the bottom line and the conclusion of the study is that induction chemotherapy followed by radical radiations and having salvage surgery as an option will reduce the rate of laryngectomy without compromising the disease-free survival or the overall survival. A decade later, there's another publication in the New England Journal of Medicine, is the RTOG 9111, and they'd like to test the winning arm for the VA trial, which is the induction chemo, and they randomize this into concurrent chemo radiations, and they add third arm with the radiation alone arm. And this is the schema of the trial. We have 547 patients. They randomize them in 1 to 3 arms. The first arm is the same VA larynx arm, 2 cycles of induction chemo, and then they evaluate. If there is no response, these patients will go for salvage surgery followed by adjuvant radiations. And in case of good partial or complete response, they will have more cycles of chemotherapy and then a definitive radiotherapy afterwards. Another randomization arm is the concurrent chemoradiation with the cisplatin. The third arm is the radiation alone arm. These patients, they were stage 3 and 4 locally advanced glottic and supraglottic cancer. They excluded the very early patients, the T1. They also excluded the large volume T4 who had invading of the cartilage, or there is more than 1 cm involvement of the base of tongue. And this trial did a CT scan also for staging workup. And then after 8 weeks of finishing the radiations, They, in case of suspicions of cancer, they biopsy that, and then they arrange for salvage total laryngectomy at 8 weeks post-radiation. Their primary endpoint was the laryngectomy-free survival, and they have multiple secondary objectives with overall survival, disease-free survival, larynx preservation, pattern of relapse, acute and late effects, as well as they did a lot of quality of life measurement. We can see here the patients and tumor characteristics. The patients were well matched between the 3 arms in terms of T2, T3, T4, as well as the end staging. Their median age was 60 years. 80% of those were male. 2/3 of the cases were supraglottic. 1/3 were glottic cancer. And then bottom line, there is no difference in the overall survival among the 3 arms. And if we see the primary endpoint was the laryngeal preservations, it seems that it is favoring the concurrent chemoradiation arm at 88% at 5 years with significant p-value. Also, the concurrent chemoradiation as associated with better local region control of 78%, 5 years with significant p-value. There is an update of this trial published in the JCO. They have a median follow-up of 10.8 years. And then again, it's showing the same message. The laryngeal preservation is much better. And the winning arm is the concurrent chemoradiation, as is the yellow line here. And then we said the laryngectomy-free survival, it seems that both the induction chemo as well as the chemoradiations are better than the radiation arm alone. There is no difference, again, in the overall survival. Interestingly, at the end and the late follow-up, there's slight tendency toward worse survival with the concurrent chemoradiations. However, no significant p-value. And then the local regional control is favoring with the concurrent better than the inductions, and then the worst is the radiation alone arm. There is no difference in the cancer-specific survival, and they have also tested for the death from not larynx cancer, and surprisingly, there was more death not related from cancer with the concurrent chemo radiation arm. So they conclude with this update that the laryngectomy-free survival, it seems to be similar between the induction as well as the concurrent chemoradiations. The larynx preservations and the local regional control is better with the concurrent chemoradiations. Overall survival trend toward improved with the inductions. However, it was not statistical significance. And in terms of the toxicity, the grade 3 and to grade 5 late toxicity is similar. No difference statistically among the 3 arms with induction, concurrent, or the radiation alone, as well as no difference in the 3 arms for the speech and swallow functions. And interestingly, they could not explain the late non-cancer death with the concurrent chemoradiation therapy. Move on, we have the GORTEC 2000 and 2001 trial for the induction, which is the best regimen we can use. Is it the 5-FU cisplatin alone, the PF alone, or we can add docetaxel, the TPF, in addition to the 5-FU and cisplatin. So the schema of the GORTEC trial, they have 213 patients. The randomization based on the induction chemo 3 cycles, either with the TPF, cisplatin, etoposide, 5-FU, versus PF with dropping out the docetaxel. Those patients will followed by having radiations for who respond to 70 gray and 35 fraction plus minus systemic therapy. This trial include stage 3 and stage 4 larynx as well as hypopharynx patients. And they excluded the one who had a prior head and neck radiotherapy or prior cancer or had a peripheral neuropathy that might be exacerbated by the adding of the docetaxel chemotherapy. So Again, also they evaluate these patients based on CT and MRI 3 to 5 weeks after the chemotherapy, and they have the option of salvage total laryngectomy for the non-responder. And also they give plus minus systemic therapy. Their primary endpoint were the 3-year laryngeal preservations, and they have multiple secondary endpoints with overall survival, assess the response to the induction, the disease-free interval, and acute and late toxicity. These are the table for the patients and tumor characteristics. It seems that slightly more advanced cancer with the TPF compared to the PF, as shown here in the N3 status, for example. And what happened to those patients for the TPF arm? They have 10 patients eligible. They evaluate 106 patients. The one who had the larynx preservation approach with the radiation is 85 patients of those. Most of those had radiotherapy alone. Some of these patients had chemo radiations. And then the surgery, the 19 out of 106 patients, 17 of those had surgery. For the PF arm, they have 100 patients evaluable. It's quite significant of those patients underwent surgery, and compared to the larynx preservations, with the only for 8 patients had radiotherapy and 9 had chemoradiations. And the primary output is the primary endpoint is the Gortic 2001 is the larynx preservations, and clearly showed here it's favoring the TPF arm with quite significant p-value, 70% at 3 years. And then there is no difference in the disease-free interval. There's no significant p-value. In terms of acute and late toxicity, the worst arm is the TPF. There is more acute grade 2 alopecia, and there is more acute febrile neutropenia grade 3 with the TPF. And then they conclude that induction TPF is superior than the PF with their laryngeal preservation at 3 years, as well as at 10 years, and remains 70%. And they update report at 10 years. And also the response rate is favoring the TPF 80% versus 59%. Moving on to the TAX 324 trial, 2 publications, one in New England Journal of Medicine, one in The Lancet. This trial tried to see and assess whether the induction TPF versus the PF followed by concurrent chemoradiation with carboplatin in head and neck cancer. And this is the schema of the trial. Their primary endpoint is the overall survival. So they include stage 3 and 4, all head and neck cancer, not only the larynx cancer, no prior surgery, no hospitalizations, and they stratified those patients based on center and status and primary site. Again, the randomization is similar, TPF arm and versus the PF arm, and then those patients will ended up receiving radiotherapy as well as carboplatin, and in case of surgery is needed, they will offer surgery. And we can see only 20% of both arms are having laryngeal cancer. And interestingly, a majority of these cases are having very advanced disease T4. More of those cases are found in the TPF arm compared to the PF arm. Because the induction chemo is a toxic regimen, there is almost 30% discontinuations because of the toxicity, could not continue the desired treatment. 65% of patients in the PF arm had treatment delay, and there is higher rate again of neutropenia in the TPF as shown previously with the Gortic trial. So kind to summarize their results, they have a good median follow-up of 72 months. Overall, there is improved in overall survival. favoring the TPF with 5.9 years compared to 2.5 years with the PF arm. Also, there is improved in progression-free survival with the TPF for all comers. However, when we look to the larynx cancer populations, the TPF only improved the progression-free survival, not the overall survival, with the PFS of 34 months versus 10 months. And then again, it's toxic regimen. There is 30% rate of treatment discontinuation of toxicity, and there is no difference in terms of the need of feeding tube or tracheostomy between the TPF and PFR. Based on the intention to treat analysis for all the patients cohort, the overall survival as well as the progression-free survival seems to be favored with the TPF compared to the PF arm. And we will look to the patients who had larynx and hypopharynx in particular. There is no difference in overall survival. However, the progression-free survival seems to be favoring the TPF arm compared to the PF arm. So they conclude that induction TPF followed by radiation, concurrent chemoradiation with carboplatin, improved progression-free survival and overall survival in patients with locally advanced head and neck cancer compared to the PF arm. The induction TPF associated with improvement of the progression-free survival and not overall survival in laryngeal cancer. There is higher rate of treatment discontinuations, around 30% in both arms of the study, and it seems that the sequential TPF followed by chemoradiation with carboplatin is a valid option for local advanced head and neck cancers. This table and this study kind of summarizes the laryngeal preservation study that I just mentioned, the VA, the RTOG, the CORDIC, and also the 2ARTC trial that because of the time limit I could not mention. And we can see those trials, the laryngeal preservation is around 60 to 80% in well-selected patients. And there is no survival compromise when we do the laryngeal preservation compared to the total laryngectomy. So it seems that the induction chemotherapy, as per the VA trial, the RTOG 9111, the GORTIC, it seems that in some European center that is favored. However, there is other multiple randomized clinical trial like the Paradigm, DECIDE, MADRID, showed no clear benefit of the TPF induction chemotherapy, but because of the time limitation, I will not go into those studies. The concurrent chemoradiation at the RTOG 9111, it seems that is favored in many of the USA centers. What about T4 in particular? And this is an MD Anderson paper showing the long-term outcome after surgical compared to the non-surgical, specifically for the T4 larynx cancer. And this is a retrospective review of 221 patients. Most of these patients, 161 patients treated with total laryngectomy followed by adjuvant radiotherapy, and they compared it to the 60 patients who had laryngeal preservations. It seems that with surgery, as we expect, there is a better local regional control. However, the overall survival is similar. And with the patients who had the laryngeal preservations, the rate of tracheostomy is 45%. There is 23% rate of aspirations, and there is increase in dysphagia with those patients. And this table kind of summarizes their results, the 5-year as well as the 10 years. So it's for all the comers and who treated with surgery or treated with the laryngeal preservation, the 5-year of survival, 52% drop almost to 30% at 10 years. Disease-free survival, 57% at 5 years, and then almost 50% at 10 years. And the local regional control is not bad, around 80% at 5 years, and 10 years almost 70%, as well as the distant metastasis-free survival. So it seems that the survival for T4 patients who had surgery or had laryngeal preserving approach is around 64 months. And the local regional control, it seems that overall there is no significant difference. However, when they look to the local regional control before the salvage laryngectomy in the larynx preserving patients, that's that the laryngectomy arm, the surgery arm, has significantly improved local regional control at 5 years as well as at 10 years with significant p-value. And they look to the fully functional larynx cancer survival. Those are the patients who are alive. There is no disease recurrence, no salvage laryngectomy needed, no tracheostomy, no feeding tube is needed. And those are 32% at 5 years, and then at 10 years is only 13%. It seems that 1 in 3 of the larynx preserving patients are alive with the fully functional larynx, with no need of tracheostomy, no need for feeding tube at 5 years. And again, majority of T4 patients will end up with having salvage laryngectomy. And for that, if you see the NCCN guideline, the T4, probably we need to treat majority of the T4 with surgery and then adjuvant radiotherapy if needed. So for the functional outcome after the organ preservation, the study from Europe, they see the organ preserving approach for these two T4 larynx or hypopharynx cancer. Is it worth the effort to preserving those T4? So this is a review from 2008-2015 patients. 36.7% are larynx, similar 34 are hypopharynx. They include all the T4 and any N status, and then see who had chemoradiations, organ preserving, and who had surgery, and then try to see the laryngoesophageal dysfunction-free survival as their primary input. Again, local control is favoring the surgery arm with significant p-value. Overall survival is similar between surgery or between the concurrent chemoradiations. And then when they look to the laryngoesophageal dysfunction-free survival, it really depends on the pre-treatment functional status. If these patients had a better pre-treatment laryngeal function status, they probably will maintain that functionality. And if they have a poor pre-treatment function status, then they will continue to deteriorate. So radiotherapy with the larynx preservation is associated with acute and late side effects that we, as a radiation oncologist, we need to monitor these symptoms for patients and we manage accordingly. There is potential toxicity with hoarseness, laryngeal edema, mucositis, dysphagia, sore throat, hypothyroidism, hearing loss, malnourishment, carotid artery damage, and risk of secondary malignancies. In larynx cancer in particular, we really need to closely monitor these patients on their review clinic on weekly basis. So we need to assess the airway. So because with the radiation, there is a concern of laryngeal edema, we need to scope those patients in doubt. And in case there's some signs of respiratory distress or stridor, so we need to have our ENT colleague by our side. And also because we radiate a lot of constrictor muscles, that as well as mucosal membrane, then dysphagia, we'll need to assess for that. We need also that mucositis might cause pain, and this reduced oral intake will lead to weight loss. So then we need to evaluate those patients for the requirement of the big tube during the treatment, and that might cause some treatment interruptions as well as brief hospitalizations. And because of the my time limitation, I will only just quickly discuss the dysphagia, how we manage and how we approach dysphagia in those patients. Usually dysphagia with the radiation started early, 2 weeks to 3 weeks of radiations. This pharyngitis, esophagitis might cause dysphagia. And the good thing is that probably the dysphagia, hopefully it will be resolved gradually, and most of the patients will have 2 to 3 weeks after radiations. And keep in mind that dysphagia may be associated with aspiration, either overt aspiration or silent aspirations. First thing is that we try to avoid and try to prevent as much as we can this side effect by minimizing the radiation dose to the constrictor muscles. And we do that by utilizing newer radiation technology like IMRT or VMAT, trying to reduce the radiation to those muscles, and then hopefully the dysphagia will reduce. And there is some dosimetric constraint how much radiation we should accept for the pharyngeal constrictor muscle. Usually the superior and mid pharyngeal constrictor muscle can tolerate a little bit higher radiation dose compared to the inferior pharyngeal constrictor muscle, as shown by these two studies. And also, we need to refer those patients to our colleague in nutrition department or dietitian department. And also they need some diet modification during the radiotherapy course. And if needed, we need to have some nutritional support aiming to reduce the weight loss and aiming to reduce the need of hospitalizations. Okay, and then also we need to refer those cases to our colleague in speech language pathology, and they will evaluate their baseline swallowing. They will explain to them the need of the swallowing exercise, what's the risk of aspirations, and diet modifications if needed. And for the PEG tube or NG tube insertion, there is two schools. Some schools do it in prophylactic setting before we start the larynx preservation approach. Either is reactive, each had pros and cons. For prophylactic setting, the biggest pros is that we might prevent unplanned treatment interruption if needed. However, there is no randomized data that's guide as 100%, and then the decision needs to be made on case by case. SLP and dietitian should be involved again. So in conclusion, the larynx preservation is a viable option of many patients with locally advanced laryngeal cancer. The treatment decision should be made on a multidisciplinary setting, evaluating what's the tumor factor, what's the patient's factor, and what's the functional status of the larynx of these patients. So future studies should be focused on improving the functional outcome and personalizing treatment. With that, I would like to thank again MESTRO. I would like to thank my colleague and brother, Dr. Isa, for again arranging such an important initiative. Special thanks to my colleague here in King Faisal, radiation oncology, medical oncology, and head and neck surgeon, as well as dietitian and speech language pathology. With that, I would like to conclude my presentation, and thank you for your time and thank you for your listening. Thank you.
Thank you, dear Dr. Mohammed, for your excellent presentation. I have one comment regarding the larynx preservation clinical trial design consensus. They suggested a new endpoint called laryngoesophageal dysfunction free survival.
Yes.
However, I think this endpoint should be laryngoesophageal dysfunction disease-free survival rather than free survival, because it's very important to include local and regional recurrences in the events. Data from KHCC I published in 2022, I included 213 patients with locally advanced laryngeal cancer, and patients who even achieved the cured, 50% of them, they suffered from dysfunction. And dysfunction also include aspiration, include feeding tube dependence. So it's really a new endpoint that we should also look at and consider for future clinical trial design, inshallah.
I couldn't agree more, Dr. Isa. Absolutely, as a well-taken point.
Another question. So we know that the standard of care for locally advanced laryngeal cancer is concomitant chemoradiation, but not all of our patients are eligible for chemoradiation because of their performance status, age, comorbidities. So how would you treat patients who are not eligible for chemoradiation therapy?
So that's a good question, Dr. Isa. In our institution, our medical oncologist colleague, sometimes if the patient is not eligible for the cisplatin, then probably they will offer the cetuximab along with the radiation therapy. Personal experience with cetuximab is not the best because the risk of more side effect, especially the mucositis. And if these patients also they are not eligible with the cetuximab because their factors cannot tolerate cetuximab, then probably I'll try to accelerate those patients. So we follow the HANCA approach. We do 6 fractions per week instead of 5 fractions per week. And that's what showed the HANCA rule. Rare occasion, even sometimes with the HANCA, the acute side effects may be issue for certain patients. Then we just do the conventional radiation alone if patients can tolerate.
A question from Dr. Ahmed Ramadan. Which patients would benefit from chemoradiation therapy without adding a course of induction chemotherapy?
So again, it's the true multidisciplinary setting discussion. Again, you need to assess the patient's factor, tumor factor, functional status of these patients. Here in our institutions, we try to preserve their larynx with concurrent chemoradiations for T3 and some selected T4A disease. We don't do induction chemotherapy a lot in our institutions for the local advanced larynx. For over T4A disease, then we'll just go for total laryngectomy because we know that the outcome probably is not the best for those patients with the organ preservations. So I know that some European centers, they're more with the induction chemo, but not in the center I work in the States. So they prefer the radical concurrent chemoradiation. I'm just also wondering, Dr. Isa, how you approach these cases in King Hussein.
Similar to your approach, Dr. Mohammed,
Yes.
we consider concomitant chemoradiation therapy for patients eligible for platinum-based.
Yes.
And we give also conventionally fractionated radiation with chemotherapy. Patients who are eligible for high-dose cisplatin, this is our preferred approach with the 3 cycles. If not eligible for 3 cycles high-dose cisplatin, then we discuss given weekly cisplatin with 40 milligram per meter square. Then if not eligible, then we think about weekly carboplatin. If not, then we combine cetuximab with radiation treatment. So if the patient not fit for cetuximab, then we think about altered fractionation using hyperfractionation, or if not eligible, then accelerated. If not eligible for accelerated, we think about hypofractionation.
Yes.
So this is our approach at KHCC.
Very simple. Yes.
So here we will conclude. We don't have more questions. Thank you, Dr. Mohammed, for your excellent presentation. And people are asking, yes, we are going to distribute these presentations. We will share the link to these presentations within 2 weeks' time, inshallah.
جزاكم الله كل خير دكتور عيسى.
Now we will have 1 hour break, so we will meet again at 1:10. So take your break and we will meet again, inshallah.
Thank you so much. Assalamu alaikum.